Item 1, attendances. In the past few meetings, I fear I've forgotten to go around the table and do introductions, which was very bad of me. So we will do that. On this occasion. This will be my last meeting as chairman. So just as I was getting into it, I should be leaving you all. And this is also, I think, Councillor Anstey's last council meeting in general. So I'm sure we'd all wish him all the very best as well. So if we can do a little round the table of introductions. So I'm Rob Chilton, I'm the chairman of this committee. Go in that direction.
Hello, I'm Sophie Taylor, I'm the vice chair of the committee and I'm a councillor for Clifford Ward.
I'm Alex Murray, Democratic and Scrutiny Officer.
Fabiola Fuschi, Democratic and Scrutiny Officer.
David Acton, Councillor for Gorse Hill and Chair of the Scrutiny Committee. Not this one.
Jane Slater, Councillor for Stretford Ward.
Heather Fairfield, Chair of Health Watch Trafford.
Richard Spearing, I'm Managing Director of Community Services here in Trafford and also work with Diane on the Adult Social Care agenda.
I'm Diane Eaton, the Corporate Director for Adult Services in Trafford Council.
Judith Lloyd, Executive Member for Health and Wellbeing.
I'm Steve Wilson. I'm Exec Lead for Finance at the Greater Manchester Health and Social Care Partnership, and I'm the SRO for the Pennine Acute transaction, which is what I'm here for today.
I'm Sophie McCormick, I'm Assistant Director for MFT and I'm here on behalf of Stephen Gardner.
Martin Pritchard, Accountable Officer, Trafford CCG.
Sally Johnston, Chair of Trafford CCG. Councillor Jane Brophy for Simply Ward, Member of the Committee.
Stephen Anstey, Councillor for Broadheath Ward.
Denise Haddad, Councillor for Hale Central Ward.
Councillor Angela Brewer-Morris, Councillor for Timsley Ward, sorry.
Tim Rhodes, Acting Statutory Scrutiny Officer.
Thank you very much, everyone. Do we have any apologies, Alex?
Chair, apologies for Councillor Laura Evans.
We have also received apologies from Councillor Denise Weston and from Councillor Joanne Bennett.
And apologies for Councillor Anne Duffield.
Super. Moving on to the minutes of the previous meeting. I take it everyone's had sight of these. Are we all content that they're a true and correct record? Super. Item 3, declarations of interest. We'll just do those briefly.
Thank you. Just notifying that I work within the National Health. Thank you.
I work within the NHS outside Trafford.
Same as Councillor Brophy, NHS worker, but outside of Trafford.
I'm Deputy Chair of 42nd Street, it's Young People's Mental Health Project.
We have item 4. We do have a question from a member of the public, you'll be pleased to know. So the new system is coming to its own. And that is from Ms. Judy Collins, who thankfully is here with us this evening, so we'll put her question in person. If you could talk into the mic, Judy, and we will get an answer for you.
It's a question about delayed discharge at Wythenshawe Hospital, which I have raised with CCG and with social services. It does look as if I know that the CCG feel that they've got a good monitoring process at Wythenshawe, but I've been visiting somebody for about 5 weeks. And it seems to me that people just aren't being moved on. And it isn't a delayed transfer of care because people are going to be assessed into care or anything like that. It just seems to be a general problem. So Wythenshawe are obviously desperate for the beds. People are being moved constantly and nobody really seems to have a handle on how to how to discharge people. I sit on the Greater Manchester Older People's Network. It's something that we're going to look into because I have a feeling it's not just Trafford where there's a problem. But obviously it's expensive. It doesn't do the patients any good. It causes a lot of worry, and I wonder how we can put things right.
Thank you very much, Judy. Can anyone field that particular question from Judy? Diane?
So we really thank you for bringing your concerns about particular individuals to our attention, and we have been looking into that particular situation. Obviously, some of the presentation we're going to give tonight, Chair, will also look at some of the work that we're doing, and it is an ongoing improvement process. We certainly aren't at the end of the game, we're in the middle probably, and the experience of individuals is really important to us. So if we do find people that are not moving on quickly enough, we're very keen to understand that situation and understand what's getting in the way and what we could do to move it out of the way. So very, very nice to meet you and perhaps we could touch base on the individual situation.
Okay, that's all right. Judy? Yep. Super. And by all means, I'm sure Dan will pick that up with you outside the meeting. So thank you very much I'm very pleased. Our first question from the public was from yourself, Judy. So thank you very much. Moving on then, item 5. Just before I move on to that, I will say we do have an item that I will be bringing up under urgent business. You can probably guess what it is, so don't all rush off. But we will go through the agenda as it is for now. Item 5, Single Hospital Service Programme Update. If we can move on to that. Yes, thank you.
Yes, so I'm here on behalf of Stephen Gardner just to kind of speak to his report. So he's provided you with a short update on progress, particularly in relation to the North Manchester transaction. I understand he's provided some detailed updates more recently on the merger integration. I can confirm that the merger integration work is continuing to progress as planned. And I think you've already received the year 1 report that the trust produced. He asked if I could just highlight that there's also a sort of a link to an animation video that the trust has produced that provides an overview of the first year of operation as MFT. In relation to the North Manchester acquisition, we're carrying on progressing that work in line with all of the NHS improvement guidance that we need to follow to do the transaction. The next stage is submission of the strategic case, and we're at the point where during March that will go to our private board for consideration, and then all being well it will go to NHS improvement and they will start their review process. We believe that the Salford strategic case will follow that process. So because it's a sort of 2-lot transaction, we've made sure that our case is consistent with Salford's case, and it'll be submitted in conjunction with that. And the timescale that we're submitting the strategic case to is consistent with the opportunity to bring North Manchester into MFT by the 31st of March in 2020. More broadly, MFT remains absolutely committed to bringing North Manchester into the trust, and we're doing engagement with staff at North Manchester, and I'm with that. The most recent event, one of our medical directors attended to engage with staff, and we had some really positive feedback. So there's good engagement, and we're hoping that can continue and grow as we go forward. I'll pause there. That's all I was sort of going to say in relation to the report, because I think the main sort of focus this evening is on Steve's item in relation to North Manchester.
Thanks very much. So obviously you've heard a number of updates over the months around the work on the single hospital service. I think the request for me to come was to give a bit more of a broader context to that around the transaction itself. So I'll talk through a bit about what the transaction is, why it's taking place, the benefit that we see that's going to derive from that transaction, and a little bit about the process that Sophie's already touched on a little bit as well. So I'll try not to fall into kind of technical jargon. This is part of a national process that is quite technical. It's set out in the NHS improvement guidance around how to undertake transactions in relation to NHS Trust and NHS Foundation Trust. So we are working. We have to work within that national system, but hopefully I'll talk through why it works for us locally and why we're supporting the work across Greater Manchester. If we cast our minds back, the process commenced with the CQC inspection of Pennine Acute back in 2016, which did rate the trust as inadequate, and that's the background to this. And that means what we're trying to do through this process is to secure the clinical, the financial, and the workforce sustainability of the services provided by that trust. We're not necessarily trying to create a sustainable trust across that footprint. What we need to do is make sure that we've got high quality services that correct the issues that were there and that were identified by the CQC in their inspection. So as Sophie said, it's technically two transactions. They are intrinsically linked, but legally they will be two individual transactions under the process. We're doing them at the same time at the moment, and the hope is that they progress on exactly the same timescale, because there are obviously interdependencies between them, and we need to make sure that the proposals from Manchester Foundation Trust for North Manchester and the proposals from Salford Foundation Trust for the Oldham, Bury and Rochdale sites fit together and align. We can't have people making different assumptions, so we need to make sure that this is taken place in a coordinated way. So those are the two transactions. You'll have heard a lot about the single hospital service part of that, and that's obviously completing the work to create that single hospital service across Manchester and Trafford that builds on the merger between Central Manchester Foundation Trust and Wythenshawe University Hospitals of South Manchester, which itself built on the acquisition of Trafford General prior to that. So this is the final piece of the jigsaw in that process. So what we're doing is making sure that we create the right governance structure across Greater Manchester to make sure that the transaction happens in the right way, to make sure that 1 and 1 equal 2 at the end of this process. They don't equal 1.5 or 2.5, and that we get the right level of assurances that what's going to come out of this process is a sustainable and clinically high quality set of services for the patients that are currently served by the services delivered across the different sites of Pennine Acute. The aim is to complete both transactions, by the 31st of March 2020. If we can do it earlier than that we will. So we'd identified the second half of the financial year of 2019-20. It is likely to be towards the end of that period, and there is a lot of benefit to doing these transactions at the end of a financial year end, which would be 31st of March. The further context, so that everyone's aware for the transaction, is that the current trust that is Pennine Acute is effectively being run by Salford Royal under a management agreement. So after the inspection by the CQC and the inadequate rating, there were a number of immediate actions that were taking place that couldn't wait for this process to play out, and that involved taking the positive models of care that had been developed, some of the workforce models and some of the leadership that had been delivered across the services provided by Salford, which was an outstanding trust under the CQC's assessment rating, and taking those benefits and delivering them across the Pennine Acute service. And we've already seen a number of benefits from that in terms of improvements of quality, which led to the CQC's follow-up inspection rating it as requires improvement, which is a step up from inadequate, and actually rating a significant number of services as good within that footprint. There is a potential conflict created that. So Salford Royal are one of the acquirers alongside MFT, but they're also in there running the trust. So one of our other roles is to make sure that we're clear on any potential conflicts of interest, and we've delivered that through our oversight, through our programme board, but also through appointing an independent director for Pennine Acute who does not report into the Salford Royal structure and is able to give that assurance. Two slides now that I think you've had the slides in advance, haven't you? So I won't go into detail, but actually these two slides are important because they set out the sort of why we're doing it. So the background is we're doing this to correct some of those issues that were there across Pennine Acute, but also do more than correct those to secure really high quality care that fits into the models of care that are being developed in Manchester. And within that, within Trafford, so the local care organisation that's being developed in Trafford, the links between the community services that you're going to hear about later today and the hospital services in Trafford, and the benefit of those working alongside that wider organisation that will serve all of Manchester as well as Trafford. And you'll have heard lots about that from Stephen over the preceding months. And similarly for the other three sites, so for Bury, Rochdale and Oldham, again, securing the right models of care, working with Salford, but also working with the community services in each of those individual areas to make sure we get the right level of care, to make sure we particularly deal with issues like those that were highlighted by the question from the member of the public at the start of the meeting, to make sure we get the right processes in place to make sure patients are treated in the most appropriate place and don't stay in hospital when they don't need to be in hospital. As I say, I won't go through those issues in detail, but key ones around on all sites, sustaining the workforce and the right level of workforce, the right quality of workforce to deliver those savings. And off the back of a poor quality inspection, one of the risks is that actually that makes these services not as attractive as they might be to potential employees. And there's a huge amount of work being done through Salford's management agreement, but also with Manchester to make sure that this is an attractive place to work, because that's at the heart of delivering these changes. So as Sophie set out, it's a two-stage process. Strategic cases, we're very much nearing the conclusion of those. So we expect those to be completed and submitted to NHS Improvement by the end of this month. And what that does is enable enough of those benefits to be set out to then make sure all bodies can commit to the next phase of work, which will be in much more detail and will take an awful lot of engagement with staff. It will allow us to progress to more progressive conversations with staff about how this will look like, and it will make sure that all stakeholders are clear that the sort of minimum level of expectations have been met, and everyone can really push forward to develop the cases. So we're really hopeful that we can move into that process. Ultimately, the decision maker is the NHS Improvement, or actually, because Pennine Acute is an NHS trust, technically it's the Secretary of State who makes the decision, but they will make that decision on recommendation from NHS Improvement. In the meantime, there's an awful lot of things we need to make sure we get right in the here and now across those services. This transaction can't be a distraction from delivering the care that's needed at the moment. So it can't be a distraction to making sure the finances are managed effectively, and it can't be a distraction to making sure services are high quality and performance targets are met where possible. So that's being overseen at the moment by NHS Improvement and ourselves in Greater Manchester. Key part of maintaining the business as usual is making sure that the communications with staff are right, and that's already been mentioned in terms of MFT's liaison with their current staff and the staff at North Manchester, and for Salford as well, they're working closely with Pennine Acute to make sure that they get the right communications with the staff in place at the other Pennine Acute sites. As those more detailed plans are developed, wherever there's need for further stakeholder engagement and public engagement, that will be developed in this next phase of developing the final business cases, and that really will be down to the individual trusts working with their local CCGs to make sure that any appropriate engagement and stakeholder discussions are held. So to wrap up, I'm happy to take questions after this. We have a clear preferred model. We think that that's the way to deal with some of the issues. One of the things I've not mentioned, for example, within this is the significant need for investment on some of the sites currently provided across Pennine Acute, in particular North Manchester. So I don't know if any of you have been to the North Manchester Hospital site, but it is very clear that significant investment is needed desperately on that site, and part of the plans that are being submitted will set out how that investment can be used to improve those services. So there is a real need to correct some of the underinvestment that's happened on the North Manchester site and the other sites. And this is a way of delivering that, and a way of delivering the right model of care that works with community services. And that's why our ambition is to support these. We need to take stock when we get those strategic cases in, following the work at the end of this month, and then press ahead towards the final planned timetable of the 31st of March 2020. I will just say there are huge unknowns in that process, the most significant of which is that the decision resides outside of Manchester and Trafford, outside of Greater Manchester. Ultimately, we are in the hands of national decision makers, the Department of Health and the Secretary of State, to get this over the line, but we will be doing our best to make sure that happens. Happy to take any questions.
Thank you. We'll move to questions in a second. I think just on this, from my perspective, and I did allude to this at the previous meeting, I totally get the rationale behind the integrating the North Manchester into MFT. I think we hear an awful lot about the proposed benefits of it, and obviously clinical outcomes for patients is ultimately what we're all about. I think it would be good to get a view on the risks as MFT see it and as the transition board see it, that are even to clinical outcomes, which I appreciate at this stage might be a bit difficult to foresee. Some of the risks and how those are going to be ameliorated, or so that I think that would be useful if we can get that as a future meeting. So
I'd just say a little bit, and then so I think you're right, and there's almost two stages of risks. There's the risk that this is a distraction in the meantime, not only to the services delivered across Pennine, but to the acquiring trusts. So there needs to be absolute commitment that doesn't happen, and we are working to get the right assurance that doesn't happen. And then the risks of the transaction itself and on transfer, and they cover a lot of different areas. Obviously, workforce is a key one, and we need to make sure that by getting the right engagement with workforce, we take people with us on this journey. Important to say within this as well, for you in Trafford, who have a hospital that's delivering well, that have an FT that's getting good ratings. Ultimately, it is their choice to take these services on. So the board of MFT and the board of Salford Royal will have to agree to this transaction. So this isn't something that can be imposed on MFT and therefore on the services that sit within MFT. They will have to approve their business case at their board in order for this to go ahead. So I think there's some assurance provided to those services that within the existing organisations that this won't be to the detriment of their services.
I think just building on what Steve said, so in terms of the sort of distraction factor, that is why we have an established team, which includes myself and Stephen, who are carrying out the current transaction work within MFT. So there's a dedicated resource focused on that, rather than using people who really need to be focused on MFT's major programme of merger integration work and delivering services day to day. Also, in terms of, ultimately it will be the board's decision in relation to the transaction, and my team's doing really detailed work at the moment, due diligence work, to understand what all of the risks are at North Manchester. So we've got really detailed, significant work going on in relation to the estate, HR, workforce, performance across the breadth. And the board will consider that in making its decision.
As I say, I'm always griping at Stephen that when he's covered the integration of MRI and Wythenshawe, he's always quoting the handful of services where the service has the way the statistics have improved drastically, and I do often say to him, we want to hear about all of them and what's being done to address all of those. So perhaps as going forward, it might be an idea for you guys to do that and make sure that we get a detailed picture. So that would be super. Councillor Longdon, please. And are you sure? Councillor Slayton, turn your mic on.
Thank you for the report. I was looking at stuff that you're talking about staff, and what engagement have you had with the staff side and trade unions?
So we haven't yet directly worked with staff side and trade unions, but that is, and actually we've had discussions in the last week about us needing to start doing that now, and we're just building towards much more engagement now, now that the strategic case is being finalised with North Manchester.
I think that, because staff will be really uncertain from North Manchester about what's going to happen to them with a potential merger, I think the trade union side could actually support and help some of that. So I think early engagement with them would be beneficial. Thanks.
Councillor Brophy, please.
Furthering on from the question about staff and trade unions, my question's similar, but focusing on a different angle. I did actually used to work for Pennine Acute Hospitals Trust, not recently, a few years ago. So I'm aware that all the issues there. My question's around kind of like more the staff engagement, because clearly when transitions are occurring, a lot of staff feel quite uncertain, insecure. They want to move on to a more job where they know where they stand. So how does that work in terms of with the two mergers happening at the same time? Is there any scope for, with the North merger happening, that maybe staff who, if their posts or jobs are uncertain, is there scope within specialised teams for people to transition between the two trusts, and how much has that been explored within the consultations?
So we're not yet at the stage of doing the sort of what we've called it the disaggregation and working out, exactly where staff go. We're just starting that really detailed, quite complex work. Services at Pennine are currently set up to work across the 4 sites, and therefore there are a number of staff who work flexibly across the site. So it's quite a kind of complex process to extract North Manchester from the other 3 sites. But what we're very committed to is that all staff will be engaged with, and will be engaged with equally. We can't have staff at North Manchester getting messages from MFT while staff who at Oldham have a message from Salford. So we're really working together very closely to make sure that we're joined up in communication and engagement with staff. But that really sort of more detailed work is what we'll be coming to over the next 6 to 12 months.
Just to add to that, regardless of the transaction, the work that was done very early on after the CQC inspection already led to some cross-working and people working between, supporting some of the A&E services in North Manchester by linking more closely with the teams in central Manchester, and a number of areas between Salford and Oldham, Bury and Rochdale where staff were working across different sites. So some of that happened anyway, just as part of stabilising the services when they hit that point of inadequate rating from CQC.
Councillor Taylor, please.
Hi, I just wanted to ask a question about is there debt at Pennine Acute Trust, and how is that going to be dealt with and amassed into MFT?
Pennine Acute, not unlike a number of NHS trusts at the moment, has a deficit, and that's a key part of the work, is understanding what happens with that. The position for 2019-20 is a significant improvement. So part of the solution is us working with national colleagues around how we can deal with some of the structural issues, because some of these issues are long standing, and they won't be solved overnight. So some of the changes that have been made to the national NHS finance regime acknowledge that some organisations are facing much more structural problems that can't be solved overnight, and there's been the creation of something called the Financial Recovery Fund nationally. Pennine's getting £15 million next year from the Financial Recovery Fund, and when the 2 acquirers set out their acquirer cases, their financial model will be expected to show how the financial position is improved, but it won't be expected to show that improvement happening overnight, and that will show how the national mechanisms around financial improvement, financial recovery funding, will be called upon by the acquirers to make sure that they can get support to balance the books while they deliver some of the financial benefits over the coming years. And again, that point around the the acquiring trusts ultimately having to choose to take this on also relates to the financial risk. So they will be cited on that financial risk, and they will be deciding whether that's acceptable or not to them. It won't be imposed on them.
Thank you very much. Can I just ask a sort of a supplementary question to that? Where is the actual funding from? Because obviously it's a huge piece of work, isn't it? And, there's 2 full-time members of staff deployed, and I'm sure you've got a vast team of people working with you as well. To actually just undertake the transition work, that in itself is costly, isn't it?
It is. So the work on North Manchester is covered by the funding that's been provided by the Greater Manchester Transformation Fund as part of the single hospital services bid that was made to that fund. Some of that was set aside for what was described as phase 2 at that point. Phase 1 being the Wythenshawe and Central Manchester merger. So that funding is in place. What we've been very clear on, though, is that that funding needs to add value. So that's not just about just paying for expensive due diligence. It's about making sure that there's the right transformation of services as a result of this transaction.
Thank you. Thanks very much.
Councillor Mrs Haddad, please.
Thank you. I agree with my colleagues about the engagement with present staff, and on the back of this, you said that this has happened because of poor quality service, and you said in your slide that you want to take the workforce with you, and you want to also promote that it's a good place to work. Are we gleaming from that you may need a big new workforce or new staff? I mean, what's the picture there? Quality service, involves staff, doesn't it?
It does, and it's no secret that the current services provided by Pennine do rely quite heavily on temporary workers in one form or another, and that's certainly something that is not desirable from either a financial point of view, because there's a premium associated with that, or from a quality point of view because of continuity of care. So we certainly see the proposals from the trust as an opportunity to deal with that. Both MFT and SR and Salford Royal Foundation Trust have a much lower level of usage of temporary staff, and we'd hope that for want of a better word, strong brands in those 2 organisations can help deal with some of those workforce issues.
Councillor Longdon, please.
Thank you, Chair. Just kind of putting our eyes back on the prize, there's a lot of detail here in terms of the 2 transformation projects. Can you remind us, what are we expecting to get for Trafford residents in terms of improved health outcomes, in terms of the financial benefits, and also in terms of improved staff experience?
So, in terms of sort of MFT, the single hospital service programme was about bringing equitable care to everybody within the City of Manchester and everyone who's served by MFT. As has been explained at the moment, that isn't the case as much as it could be for residents in the north of the city. We are absolutely committed as MFT that the service received by Trafford residents won't be altered or disadvantaged by the work with North Manchester. And we want a strong and viable trust going forward that is really attractive for the best staff to come and work for and provide services for residents. So I think it just completes the kind of jigsaw of the single hospital service for the whole of the city and Trafford.
Can I just ask a supplementary? I mean, forgive me, I'm a new member to this committee, so I'm still doing a lot of learning as well. So would it be fair to say that the focus of the transformations are geared towards the north of the conurbation?
No, so we're doing an awful lot of it. It's been a 2-stage project. So we've initially had the merger of Wythenshawe University Hospital South Manchester and Central Manchester Foundation Trust, including Trafford. And there's an enormous amount of work going on within MFT currently to integrate services across the trust and ensure that every service is taking the opportunity of the merger to improve services for residents across the city and Trafford. So this North Manchester is only one part of it really for us, and a significant amount of the work that the single hospital service team is doing is still very much focused on the merger and the improvements that come from that.
If I may, Chair, just a supplementary question. What you're saying to me is that Trafford residents will also therefore get improved outcomes as a result of these transformations. Have we quantified those?
So in terms of the current merger integration work, we have a sort of detailed programme of work in terms of, and we're tracking the benefits. So right from the very outset of the concept of the single hospital service, we outlined benefits that would be delivered for residents, and we're tracking those through, and we've got a very strong kind of project program management approach that's running through to make sure that we are evidencing that and can say, if somebody comes back to us and said, did you committed to delivering X, have you done it? We will be able to evidence that, and if we haven't achieved it, explain why, and we've got processes in place to ensure that we do deliver, and that where we're not delivering, we know that, and we can put in place sort of mitigations to ensure that we do.
And if I may, Chair, just one final question. When are we likely, this committee, to see that update report in terms of those outcomes and how they're progressing against the original?
So as I understand it, Stephen's provided previously updates on the merger integration work. What I would say is this is a huge programme of work. So the focus for MFT in its first year, and you'll see that when you read the year one report and potentially watch the animation, is that we needed to keep the trust stable. And it sounds very simple, just kind of keeping the lights on, keeping things working, but actually this is a really quite big organisation, and if you'd have looked back several years ago, you wouldn't have thought the two organisations would have come together. So there's been a lot of work to do to keep things stable over the last year. What we have been doing is over the past year to 18 months is working on the Trust's clinical service strategy and the group strategy in terms of how it operates as such a large organisation. That clinical service strategy is sort of going to be the real catalyst for the bigger kind of more significant changes that we can make to services, and that will happen over the next 1 to 5 years. It's a big programme of work, and changing things in the trust, it's like a jigsaw, and you start moving things, so it's a long-term piece of work.
It brings back to my point really that it's all very well to track the benefits, but this committee is also not just interested in the benefits, we're also interested in things that aren't working as well. And as we discussed before, Stephen often refers to because of course the merged MFT will impact everybody who lives within that area, because of course services are being brought together under single sites in some cases. And for instance, Stephen I think alludes to gynecology service quite a lot, and the fact that those outcomes have already improved, which is great, but that is one discipline, and we really need to be drilling down as soon as you guys can. And I appreciate it must be difficult to get a clear picture when you're at this stage, but of course Wythenshawe and MRI have merged, and I would hope that at some stage fairly soon we'll be seeing a clearer picture on where patient clinical outcomes have been affected, whether they've been affected well or whether they've been affected poorly. And I hope that MFT can be transparent with this committee about that. We're delighted to hear about benefits, of course, for our patients, but we also need to hear about where it isn't working. And I think that's what you were getting at as well, wasn't it?
I think really just to win the committee to give us an idea, can we have some firm commitment when we'll get that information? I agree with you entirely, Chair, but I think we need to push a little bit further and ask for a time, a place, when we'll get that information.
I think in fairness, it's more the approach to the committee, and it was brought up at the last meeting. We do need, and of course, appreciate Stephen's not here this evening, but we do need that, certainly from a North Manchester point of view, where stuff is currently there and disciplines are there. It's difficult at this stage to get that timescale because, of course, it's not even happened yet. But where services are now embedded, either in the Wythenshawe site, Trafford General, MRI, we could do with getting a full picture of those services. Perhaps that's something that you could bring to the forthcoming meeting.
Absolutely, I can take that back and talk to Stephen and agree an approach with him.
If there are no more questions on that, can I thank you very much for coming to speak to us this evening. It's a very important piece of work for this committee to be looking at, and thank you for all the work you're doing. So we look forward to seeing you again in future. Thank you. Moving on, item 6, diabetic services, which is page 25 to 30. Report from the Corporate Director of Commissioning. Have we got somebody who can speak to that? Is that yourself? Oh, you're behind us, super. Do come round. So if you could perhaps just introduce yourself and then we'll go on from there.
Yeah, no problem. Thank you, Chair. So my name's Brooks Kenny. I'm Head of Scheduled Care for Trafford CCG. So I'm here to talk about the diabetes work that the CCG is currently undertaking and talk through the paper that you've received. I've also got with me Dr. Clive Markey, who's our clinical lead for diabetes, but he's also been a Trafford GP in Sale for over 30 years. So he's here as well to talk about the work that we're undertaking. So my proposal is just to kind of take you through. Hopefully people have had an opportunity to read the paper that's been submitted. I'll just try and give a reasonably brief overview, because hopefully people have had, like I say, have had a chance to read through it. So diabetes, generally speaking, is a massive issue for the NHS. It's resulting currently in 22,000 avoidable deaths per year nationally. There's an increasing national prevalence, partly due to the rise in obesity. It's a long-term condition with the fastest rising prevalence, and if not treated properly, it can result in serious life-threatening complications, including renal dialysis, blindness, cardiovascular disease, kidney disease, and amputation. And Trafford's, it's not really too much of a different picture to the national picture. Again, diabetes is on the rise. Particularly, we've got an aging population as well, and calculations tell us that we've currently got approximately 11,500 people with type 2 diabetes. So it's an area that we need to do something in. It's an area we need to do something to provide better care for these patients, and that's what we've tried to set out in the body of the paper. So in terms of the work that we're planning to undertake over the next year, one of the key pieces of work is the Diabetes Hub pilot, which is currently underway, being delivered out of Partington. So the pilot, the service is currently being offered to 25% of the diabetic patients at both the Partington Central and the Partington family practices. It's led by Dr. James Hyder, who's one of the GPs at the Partington practices, and it's also supported by Clive as the clinical lead. So it's been operational for 9 months, and it offers improved care, which is delivered closer to home, should offer better value for money as an alternative to treatment in secondary care. And I think one of the really important things that's been piloted in Partington, which is an area which has typically got high prevalence of diabetes and has historical problems in terms of inequalities and access to wider services within Trafford. So in terms of the benefits that the hub's offered, it's been running for the last 9 months. It's resulted in a reduction, a third of appointments, first appointments at hospital for the cohort of patients, and a 36% reduction in follow-up appointments for that cohort. It's also resulted in an 18% increase in the number of patients who are receiving all of the 8 care processes for diabetes that are set out in NICE guidance. So it's the outcomes are really positive. Dr. Hyder's personally is extremely positive about the pilot, and he's recently appeared on TV talking about what's going on there, accompanied by a patient who's actually managed to reverse their diabetes entirely with support from the hub. So that's one of the critical pieces of work. In addition to that, we've got a number of pieces of work ongoing within the TCC, or Trafford Coordination Centre. So in terms of referral management, we're currently looking at all referrals to hospital from GP practices, and those are being reviewed in conjunction again with Clive, and where appropriate, those are being diverted back to the GP practices with advice and guidance. And to date, that's prevented 27% of referrals into secondary care. We're also looking at repatriating the Partington patients, so where appropriate, shifting their care out of a hospital setting and back into the GP practice. It's obviously important for the patients, they're getting their care closer to home. and obviously that also delivers financial benefits. And finally, we're looking at implementation and rollout of a diabetes advocate role, which is again delivered by the TCC nursing team. So that's to support the wider diabetes population. So those are kind of individual little pieces of work that we've got going on. So the next steps are to roll out the diabetes hub across all of the Trafford neighbourhoods, and that's being worked up as part of a business case, which is at the development stage. So the plan is to initially we'll roll it out to one more hub, so one more practice, which hasn't yet been agreed which practice it will be, but it'll be based on analysis of the prevalence data. So we want to pick somewhere we think it can have the biggest impact. And then we'll expand the pilot model out into the other areas in Trafford with highest prevalence, which might potentially be the north of the borough in the first instance. And really the aim is to try and create a standardized model of diabetes care across Trafford, to reduce variation across GP practices, and create a kind of a clearly defined standard of care. So patients, GPs, everyone understands the standard of care that we expect them to receive from their GP practice, and ultimately create a model of care where only the patients, the most complex patients requiring specialist care, need to be referred on into secondary care settings. So the benefits really of the model are patients being seen closer to home, an improved standard of care, improved outcomes, reduction in variation, reduction in diabetic complications, and reduction in spend and savings to the healthcare economy as a whole. So the next stage to roll that out, like I say, there's a business case in development, which will be worked up over the next 2 months. We'll be looking at the outcomes from the Partington hub pilot, building those in, scaling them up, and creating kind of a timetable for rollout and a methodology by which we'll be able to track the benefits, both in terms of health outcomes to the patients, but also the financial benefits that should bring. So hopefully that kind of gives a bit of an overview of what's in the paper and the work we're doing. Clive, I don't know if there's anything you want to add to that from a clinical perspective.
Diabetes is a massive problem. It's, I don't know, if you've got diabetes, you want to ensure as a patient that your needs are met annually. For those that are not in the know, the care processes are things you'd want to have done to you over 12 months to maximise your day-to-day well-being and minimise the likelihood of development of complications, and if those complications are developing, have them treated appropriately in the right way. Historically, most diabetics have been looked after in the hospital sector. That is no longer tenable. I work in the hospital diabetes centre at Trafford General, and I've been doing that as long as I've been a GP. And 30 odd years ago, 40% of the diabetics were type 1, 60% were type 2. It's now 90 to 10. Enormous exponential growth in type 2 diabetes. And it is not sustainable for those patients to be managed in hospital. And these patients need to be looked after at home. If you've got raised blood pressure as a patient, you don't expect to go to hospital on day one. You expect your GP and a practice nurse to put a cuff around your arm and look after you. And the culture in primary care is changing, that they are absolutely getting up to speed with the provision of care. The hub has come about because there has been some difference in provision. And I think the hub has already been able to upskill the practice that's been hubbed, if you like, and they've been very motivated to take on the thing. And if you take that across Trafford, it surely has to be a win-win. Patients often, even if they're under the hospital or attending general practice, there's a duplication of care. Patients have 2 sets of blood tests for the same condition the same week. That's a nonsense. By provoking this model of care, we can streamline processes and improve the patient journey. There are drugs now available for type 2 diabetes that not only look after your sugar, but actually will keep you alive. That is maybe quite as controversial as a statement to make, but historically, actually, most diabetic drugs haven't been geared to keeping you alive. They've been look after your sugar. We've now got drugs. If you're on them, you're going to live longer and have less likely to have a myocardial infarction, end up in the cardiothoracic theatre. So, but these drugs are new. GPs need to know how to use them appropriately, and that's part of the process. I'm visiting all the practices bit by bit and giving people confidence to use this, but the hub provides the means to do that in Partington. If we roll that out, then the drugs that actually mean things. We all want to live longer. You know, people are going to become doctors and nurses because they hope they're going to save lives. Well, we've now got the opportunity to do that. Let's use it properly. It's a massive problem, and I think these are the first steps to make a difference. The referral reduction that's come about is actually about a third, and that in itself provides a vehicle for education for the GPs. So each and every referral that I feel could be managed further in primary care, I have a one-to-one with the GP or the practice nurse, and so the next patient comes in with the same issue, doesn't necessarily end up in a hospital visit. It's to be welcomed, I'm sure.
Well, thank you very much. And that it seems like a really excellent and worthwhile piece of work, and I do hope this can be rolled out to the rest of the borough. And thank you again very much. We'll just have a few questions, if that's all right with you. Councillor Mrs. Brewer-Morris.
Thank you very much, both of you, for your speeches this evening and this paper. I really welcome it. I'm a practice nurse. I work in central Manchester, and we have an enormous amount of diabetics. And I appreciate the care. At the moment, I'm doing a 3-day course. Well, I've just completed it on the new medications that are now being provided. But what I wanted to say is a couple of things. Currently, only 1 in 5 people with diabetes are achieving all the 3 standards. It's really, really poor. Yeah.
Historically, we've got the 8 care processes include 3 blood tests. So someone tickling your feet, dipping a urine, asking if you smoke, checking your blood pressure, and weighing it. But practices have got to have the devil own job of actually achieving the care processes. Once you've got the blood out of a patient, then is the action to act on the blood result. But the infrastructure historically has not really been supportive of continual follow-up to improve the situation where, say you've got a cholesterol that's elevated, well, actually to act on it and then follow that up. You know, you do it for a few, but actually you're also busy spending your time trying to chase those that haven't had the blood test. So but that mirrors your comment.
I'm just saying, actually, I agree entirely what you're saying. It's the diabetic care should be in the GP surgery. Don't forget that we need to train the practice nurses, because it falls into her remit to look at all the results, look at everything to make sure they're immunised, to do the whole thing, to go through the 8 care processes. I'm very disappointed there's only been an 18% increase in patients who've had all the 8 care processes. Are you following the Manchester standards? This is what we're doing at the moment. We obviously follow QOF, but we've taken the Manchester standards, and they're far more difficult, and it's more intensive, the care that we now give our diabetes. Can I just also want to just very quickly, the 12,500 that we have in Trafford, this is just the current diabetes. We know, are we being proactive in finding the diabetics that are actually out there? Normally, the diabetic has been 7 years undiagnosed as a diabetic before they become a diabetic. And these are all things that need to be looked at. But I really, really welcome it. It has to be it has to be welcomed. I'm surprised that the hub was first in Partington and not in North Trafford.
Well, can I?
Yes, please do.
The hub actually started off both in Partington and North Trafford, but I'm afraid the North Trafford hub had to be stopped for there was an issue around the qualifications, I think, of the hub providers, and so the CCG took the view that the hub had to stop. So it was set off in both places, and in fact, the initial locus was to be North Trafford, and Partington was the add-on, if you like.
There's probably the need is rated in North Trafford.
Oh yeah, well,
my experience.
I think that both areas of our community there are needy, and North Trafford is an area of where there have been issues. But actually, in the very recent past, one of the practices in North Trafford has appointed 2 very qualified GPs in the diabetes world. And they're making an enormous difference already. And with their own population, they're actually facilitating the discharge of patients from the hospital sector. They're keen to take that. I mean, I don't know the position for Manchester, but how many patients are looked after on insulin, for example, in the community. But this practice is now embracing those patients with insulin. 50% of the type 2s in the hospital sector at Trafford General are on insulin. Most of them are stable, but don't need to be in the hospital sector. But GPs and practice nurses historically have run a mile when they see someone's got an insulin prescription because they're not confident about managing it. But we're trying to upskill that. In answer to your question about the Manchester standards, we can only look over with envy. So we have tried historically to agree a minimum of what is the capability and capacity for a general practitioner, a general practice for delivery of diabetes care. And we are now just in actually having that debate to get a consensus of what should be core general practice. And if you're not able to do that, then that has ramifications for education and upskilling and the rest of it. But equally, that core general practice definition would identify the very patients that would be fed into the hubs when it's rolled out. So the two go together.
Just very quickly, just one thing I've learned just recently on one of my updates, that 1 in 3 patients occupying a bed in Manchester Royal are diabetic. In the country, it's only 1 in 7. So the need, diabetes it's happening. Thank you.
Councillor Longden, please.
Yeah, thank you. Yeah, just looking at the bigger picture. By the way, thank you very much for the comments from both gentlemen. And I think it's really interesting to see that we've got models like this that are working and improving and having an impact. So thank you very much and well done. I've got you both in the room, so I want to ask bigger picture questions. Clearly from the introduction, we can see the impact diabetes is having on mortality rates and the impact it's having on what we would like to think is avoidable deaths. We've talked about Partington, we've talked about North Trafford. So clearly there's a link there around poverty. Nobody's mentioned that word today. We need to look at longer term solutions. What if you had the Prime Minister in the room and you want to advise her strategically, how would you advise her to reduce diabetes? What would be the one big project that would deliver the biggest bang for bucks in terms of reducing diabetes and therefore death? Could you elaborate on that?
Sorry.
Could you elaborate on that?
Education. Yeah, patient education. Sorry, not particularly. I've no desire to sit here at all. How do I press that?
Could you say on the education, would that overcome the impacts of poverty as well?
Well, yeah, okay. Patient education provides the patient taking ownership of the problem and understanding what the situation is. Of course, in any group of people, there'll be a difference of getting it, but there are 2 education programs for diabetes currently running in Trafford. There's the TIDE course, which is type 1 diabetes education, and that mirrors DAPHNE, which is the national program. And that is a particular program designed for type 1s. Type 1 diabetes is actually a very different condition from type 2 diabetes. Type 2 diabetes, the education program is called Expert, and it's a commissioned service, and every new diabetic is offered the opportunity to attend an Expert course. But the take-up is only about 15%. And the take-up is 15% irrespective of which part of the Trafford you live in, actually. I certainly feel that there are there's scope for parts of the community to reinforce that. In North Trafford, I'm sure that the mosque would be a very powerful proponent of diabetes to encourage that. And similarly, in South Trafford, the uptake is no better. But going on an education course which is tailored to the individual will provide the individual some ownership of the problem to get to understand what the issues are and maybe take some responsibility for their own lives. We've heard today about a patient that was on television that Dr. Hyder was involved with, who you may have seen the program, but whose diabetes had gone from a level of HbA1c of 80, which is the sort of measurement that we use, down to 46, which is below the level at which you diagnose the condition. Diabetes UK yesterday, and it's in the front page of some of the papers today, show you can cure your diabetes. Yeah, we're very lucky actually in Trafford. We've got Dr. Sarah Stephen, who did all the work in Newcastle before she became a local consultant. So by reaching out to patients and providing them the means on a one-to-one basis to encourage them to be involved in self-management, giving them the time to do that, and that is across the board, then you can have a real impact for the well-being of that patient, reduce the problems they've got, facilitate their well-being, and for a good number of them, hopefully, make their diabetes disappear.
Thank you. You've answered part of my question on the education front. As an educationalist, completely see that, and you focus very much around kind of people who've already got diabetes. But we've seen a huge increase in diabetes.
Yeah.
So there are plenty of people, and I think we all agree, prevention is better than cure. I thought as a society we were getting better educated, not worse educated. So what is happening there? And go back to my other question: has poverty got any part to play in this?
Some practices, not all, but some practices in Trafford are signed up for the National Diabetes Prevention Programme. So, and this is about identifying those patients that are at risk of developing diabetes given enough time. And these patients are provided with lifestyle advice and the rest of it. Is poverty an issue? Undoubtedly, poor lifestyle is often associated with low income. I think the evidence is there for all to see. So yes, I'm sure that in Trafford we've got a discrepancy of population, but in the leafy suburbs, some folks' lifestyle is going to generate diabetes just as much as somebody without the money who can't seemingly afford to approach and embrace what we would call a healthy lifestyle. Undoubtedly, the less bob you've got, the more likely you are to lead a life that is perhaps not what the textbooks would advise you to be doing.
Thank you very much.
Thank you. Councillor Brophy, please.
Okay, thank you very much for your comments and for your work there and reporting on it. I'll just be upfront about where I come from this. When I'm not a Trafford councillor, my work for the NHS is working with people with diabetes. I work in West Yorkshire and we have NHS England funding, and the funding is to increase the uptake of education for people with diabetes. So as part of my role, it's quite right to look at poverty and where the most need is. I think I was just thinking about some of the figures that were presented. I mean, quite clearly, you've got here that there's 11,000 people in Trafford with type 2 diabetes. I think that illustrates the kind of scale that we're looking at in Trafford, and also the scale of the issue for Trafford CCG. And after all, we're a health scrutiny committee, so it's our job to look at, what's possible, how we can make this happen. Clearly, there's a lot of work going on the prevention side already with others in this room around sort of health and well-being, and the work of our Director of Public Health in leading the prevention in the first place. So that's key to our scrutiny as well. But it's also, I'm just thinking your 15% of people offered expert course. I'm aware expert it's a 6-week course of 2.5 hours every week. It's actually a big call for people to offer that. I'm wondering if that 15% is actually 15% who are actually offered the course, because one of my areas of work, and I would like the CCG to find this out, I can't see that there will be the capacity for 15% of people with type 2 diabetes to be given the expert course. I suggest it might be that it's 15% of people who were offered it. One of the things that's very key in terms of education is actually offering people that education. It requires quite a lot of work to be done with health professionals, with other GPs, with practice nurses, with the wider health professionals out there, because quite often people aren't offered the education. Quite often the education itself, the 6-week expert program, it isn't for everybody. It's a big commitment. It's quite a high level course. And one of my areas of work outside of this committee is to develop a course that's a short course for people who want something a bit simpler, a bit less of a commitment. Also, we do it with language support. So for areas where people have English not as a first language, then we've been quite innovative in NHS England. So I think if we are going to have a working group on this, I offer myself for this area of work with my background. But I also think there's a lot not in this report. So I commend you first on the work that's been done in Partington. I wonder whether the Partington model would actually apply to other places. You've already alluded to the fact that it didn't work in the north of the borough, for whatever reason that was. I think there needs to be some quite careful scrutiny of what this model is, how it would work in other parts of Trafford, looking at the education offer, going back to the other councillor's suggestion there with the expertise in this committee. I think there's a lot that's not in this report as well that we as a health scrutiny committee need to scrutinise. And I think that when we are scrutinising, we scrutinise on that, what that offer is for all the 11,000 people in Trafford with type 2 diabetes. And that is a big ask. And I think there's a lot more here, and would be happy to contribute to further work on this.
Can I answer that? The 15% is the 50% uptake of the offer. It's not 15% diabetics. So, yeah. There is a 1-day expert course, which is offered locally. In fairness, the people who provide the expert course don't like doing the 1-day course. They don't think it's comprehensive enough. And I absolutely agree. Why would you go to school 6 days when you can go to school 1 day? So and any help in that would be great. And I don't think expert fits the bill for everybody. I think there are issues around language and the rest of it. I think that's a very positive thing to be taking forward. The North Trafford pilot didn't get off the ground because of personality, not because it was felt not to be the hub not to be suitable. So, but I think you're right. I think one thing doesn't fit all, and the provision of care around Trafford is variable, and where there's good general practice and they're providing good care, that would be a different situation. But there are some basics that need to be achieved for your patient, and we've got to start somewhere.
So,
can I also follow that up? I think I'm really keen to hear the passion and enthusiasm and all the good work you're doing in Partington. But as a health scrutiny committee, we've got to be scrutinising services for all of Trafford. And that's why I would like to hear a bit more from the CCG, really, because as a health scrutiny committee, we're wanting good services for all of Trafford. It's great that you've got a good model off the ground in Partington, but I still question how and the funding, how we would make this work across all of Trafford.
Something we can address directly to the.
So I am addressing my question to Trafford CCG.
So shall I, if I just address that? So I think the issue is we absolutely recognise that within Trafford we've got, well, if I address the kind of expert patient query first. So I think we completely agree. I think I recognise the comments that you're making. I think we're not convinced, and clearly expert isn't for everyone. It's not accessible to everyone. It's a big long-term commitment. We need to look at what the uptake of that course is. The current course has quite high DNA rates as well, and all of that adds up to suggest that maybe it's not the right education course for our patients. So we've been over a period of some months working with colleagues at Pennine Care to review the services, particularly as those services go into a point where they're going to transition to provision by Manchester Foundation Trust. So the expert programme will be reviewed as part of that wider piece of work, and I think we need to look at very carefully, we need to think about what is the right programme of education for our patients that we can put in place. So I completely agree. I think that is something that we need to look at moving forward. In terms of what's going on for the wider population outside of the Partington hub, I think it's absolutely our intention that we address the issue of diabetes across the entirety of the Trafford population. I think the Partington hub should be viewed as the first step to doing that. I think no one's saying that we've done a piece of work and we're going to sit back and think we've achieved something in Partington and we're happy with that. I think it's about now working through a business case in terms of how we scale that model up, and completely accept that it may need to be tweaked. It may not be a one-size-fits-all offer. What worked in Partington might not necessarily be immediately replicable in the north or the south, because the health needs in those areas are different. So we need to look at what are the health needs on the neighbourhood model and tailor the solution to meet those needs. But I think what Partington does give us is a template that we can use and that we can build on to roll out moving forward. I think it does give us some real good evidence that the approach that we've put in place can work and can have benefits, both in terms of benefits to patients, but also in terms of a shift, a transition in care away from the hospital and back into the community and GP practices. So then you're right, we absolutely need to look very carefully about how we roll that out. It isn't a one-size-fits-all model, but we're absolutely not for a second saying that we are not looking at delivering something that's a pan-Trafford model for diabetes. And I think that the critical thing is that we need to create a standard of care across primary care. And because of the current variation in GP practices, between neighbourhoods, that's not in place at the minute. So we need to try and create a template, which I think we've done in Partington, that can then be rolled out and try and create a standardised model across Trafford.
Quickly, please, Councillor.
I think obviously Partington have done some good work there to start with, but I also still question what's not in this report. There's nothing in here about the actual outcomes for those patients. The only thing that's a positive that's worth celebrating here is the fact that people are moving into the community care, which is a good thing in itself. But as other councillors have highlighted as well, there's nothing in here about the staff training to support the hubs and to support it. Other councillors have talked about this, that it requires quite a lot of expertise to set up hubs and people, and I'd just like to see a lot more. I don't feel that there's enough in this report to tell us as a health scrutiny committee what we need to know to make sure that those 11,000 people in Trafford who have type 2 diabetes, because this is what it's mainly about, are actually getting a service which does tick the boxes for nice guidance. And I echo the comments of the other councillor that actually an 18% increase and the numbers that aren't getting that standard that is acceptable and nice standard, that's what concerns me. I think that's, as a health scrutiny committee, we want to be looking at what's not happening as well as celebrating areas of good practice.
So yeah, that absolutely makes sense. So I think it's potentially an issue of timing, because we've come to the end of the pilot in Partington. So the next stage is working up the full business case that should address some of the issues that you're raising. So we'd be very happy, I'm sure, once we've fully reviewed Partington, over the next few months, we'll be working out the strategy to roll out a model of care, a standardised model of care across Trafford. So I think once that's worked up and we're still in the process of developing that, we'd be very happy, I think, to bring that back for you to have another look at, because I think at that point we'll be in a better position to address some of the issues that you're raising about exactly what we're going to do in different neighbourhoods around Trafford, how we're going to resource that, how it's going to be supported, and we can also bring back further information about the specific clinical outcomes that have been delivered, both within the Partington pilot, but also the kinds of outcomes that we'd expect to see across the wider Trafford borough.
Just to clarify, I think it will be necessary to bring this back at the next in the next municipal year, because this is obviously going to develop. And you mean, in fairness, you did make it clear that it is a pilot. And whilst I'm sure most of us would have liked to have seen something in place much longer ago than this, it is nonetheless pleasing that the pilot is in place. Can I just ask members, because we do need to make progress, just to make I have some speakers just to make their contributions as concise as possible. Councillor Mrs Haddad, please.
Yes, thank you again. Just echoing my colleagues, it's an excellent model of care. And because we're talking about standardising and demographics and things, I just happen to know, being a healthcare worker, that Qatar, which is one of the richest countries in the world, has got the highest death rates from diabetes. So it isn't particular to the social demographic, it's more about lifestyle, as you said. So I just wanted to say that. But to be brief, you inferred that, quite rightly so, that it's infrastructure that has been the problem in the past, and I'm sure it will be the biggest hurdle for the future. And that's where one of my concerns lies, is because, the capacity of GPs to be able to do this is going to be, is it a big ask? And secondly, to that issue, is that I actually saw this week advertised by Lloyd's Pharmacy recruiting for specialist people, and I'm just wondering, are we going down that route where the pharmacies are going to be starting to do these things? Is that something you are? And finally, what my final point was. Finally, that was my final point, was that we've had in this forum a conversation about the Altrincham hub and, the precarious nature of that at the moment. Is it not something that you could work with them to develop your model, and use that facility as a...
Yeah,
Yes.
I mean,
I'm sure.
I do come in on that. I think that we will touch on the Altrincham hub later. I think that there's a great deal of problems with that.
Altrincham hub, Chair, it was more about, resource capacity in GPs.
I don't wish to blow my own trumpet, but I think I've been a bit of a one-man band for 25 years. And you probably realise I've got some grey hair. So I'm not going to be around forever. And it's very heartening, actually, that there are folk in Trafford now who are putting their heads above the parapet and are prepared to take on the mantle. But infrastructure is key. And I think the CCG have got to come to a way of working to perhaps reward practices for going that extra mile, which would mean they don't have to be seen in a hospital. So there may well be a cost benefit for looking after these people. And if GPs are developing portfolios, people who have different ways of working, I think for the future, I think I can see in the future a group of practices will have a diabetologist within it, and a couple of diabetic specialist nurses. There is not one community diabetic specialist nurse in Trafford, not one. And I am the community diabetologist, which well, they're pretty thin on the ground, but there isn't one community diabetic specialist nurse.
I just finally got to keep this brief, but I'm sure that's something that will be in your business plan that you'll be looking at. Yeah.
Councillor Taylor, please.
Okay, thank you very much. Yeah, it's very promising, and it's already shown some quite good outcomes. a question then is probably to the CCG. Can this, I mean, the implications of both identifying and managing type 2 diabetes effectively are absolutely huge, aren't they, in terms of keeping people out of hospital, preventing all kinds of morbidity and mortality, really. Can it, you talk about sort of rewarding practices for undertaking this role, can it not be mandated almost? I know you can't tell practitioners how to manage their patients, but the implications of it are so huge. I'm quite astonished, really, even though this pilot shown some really great outcomes. It sounds to me like it's been quite neglected, really, and you have been, sort of championing and, evangelizing about it over a long period of time.
Well, I think there's, I go back to your Manchester Standard Care, that's the blue ribbon,
That's what we all should be short
and
Trafford, isn't it? And then two ways about it.
we are presently trying to set up a consensus that would be core general practice, and it's not for me to say what should happen to people who are not prepared to commit to that. I just manage sugars. But
the implications of it are so huge, aren't they?
Well, indeed, I couldn't agree more. I mean, it's something I've raised 15, 20 years ago.
Yeah.
But
So through the chair, can we agree as a committee that we're going to do a lot more work to scrutinise this?
I will. I was going to bring that up at the end. We will, I think, be bringing this back in the municipal year with a view to potentially setting up. I mean, obviously it's the next committee to decide what will the task and finish work will be, but this could certainly come under it, and we will be bringing it back. So definitely. I have just two.
I was going to ask another point.
Sorry, Councillor Taylor.
Just really, really quick. Just as somebody who does represent a ward in the north of the borough, we have a really diverse population, and I think something to consider is how is this offer rolled out to a very ethnically diverse population. And I mean, I'm clearly no expert, and I'm sitting next to an expert, but it is recognised, isn't it? I think that the incidence of type 2 diabetes is higher in particular sectors of the population. How could, I mean, you mentioned about using the mosque and, but I think there's probably a lot of unidentified and undermanaged diabetes, isn't there, in certain sectors of the population?
There are very good examples of exemplar care in Blackburn and Bolton.
Yeah.
And we haven't got to go very far up the M60 to heed those lessons. Bob Young, who was the senior diabetic consultant at Salford Royal Hospital until his retirement, set in place the National Diabetes Audit, which has provoked the data collection regarding 8 care processes. Is adamant that the provision of optimal diabetic care is about practice administration. And
sorry to cut across you, but the point that the Vice Chair was making was about the ethnic diverse communities. And again, I think, sorry, So, all right then, thank you, yeah.
I've already talked about Bolton and Blackburn having exemplar provision of care to the ethnic minority communities in those areas, and I think there are lessons to be learned from there. But I'm talking about practice administration across the borough, and irrespective of which part of Trafford you live in, if you've got a practice that's well administered and has the systems in place to facilitate patient observation, patient care, delivery of patient care, then the provision of those 8 care processes and the optimal management thereof will improve exponentially. So yes, I think there are particular problems, but I don't wish to comment about individual practices, but I'm sure there are practices in Plymouth that are better administrated than there are practices within the Trafford boundaries.
I think we can probably do the guesswork for you, but yes, thank you very much for that. Just 2 brief questions just to finish off then I have. So if you can be very as brief as you possibly can, Councillor Mrs. Morris and then Councillor Longdon.
Thank you. Yeah, I agree with everything you're saying, and Yeah, I just wanted to say about the expert patient, the expert care, Manchester Royal, who has a lot of our patients from North Trafford as their patients, are offered this. It's a couple of afternoons. And one session is in Urdu in the health centre where I work. The take up is bad. It's like pulmonary rehab. You just offer the patients this, and they don't want to take it up, but it will bring a lot of relief for the lungs in terms of. And it's the same with our patients. What we have been looking at just recently is though patients are offered this within the 6 months or 1 year of being diagnosed as a diabetic. Sometimes later, 4 or 5 years later, we should be then saying, do you now want to take the course? But it's not paid. It's money again. But in Manchester, we are looking about offering this ongoing diabetics a course. Thank you.
There are certainly patients who have refreshers 5 or 6 years later. And certainly, when I was at school, I would want to know my maths times table 2 years later that I still knew it. It's no different to that. And it's all about provision. And if you've got folk who are able to deliver it on a one day, but there's 2 people who can deliver expert. They've also got day jobs as dietitians. It is an infrastructure issue, really.
Yes, so if we're focusing on this still...
Councillor Brophy, I'll just bring Councillor Longden in first. He has been waiting quite a long time. Can we just do this in order, please?
Thank you, Chair. I just wanted to ask the CCG, who's focusing in Trafford on the real preventative stuff, which is working with young people, because we know diabetes increased massively with young people. Who's doing anything in that area, if at all?
So in terms of working with young people, a lot of the commissioning of younger people's services sits over here with the council and with public health. So we work closely with colleagues here, commissioners here, and public health to look to commission services for our younger population. I think you're absolutely right. Again, I think it's critical, and it comes back to Clive's point about education and when we start educating people about. One of the key things has got to be about diet, and when we start embedding those messages. So I completely take on board your point. One of the other points I wanted to make earlier when you mentioned poverty, I sit on the GSNA steering group, and that steering group's just identified poverty as its key theme for this year. The Joint Strategic Needs Assessment. So Joint Strategic Needs Assessment is a document that exists online that is a review of the kind of demographics and healthcare needs of the wider Trafford population. So I think that's a really good opportunity to feed in both around education for all ages, but also the poverty question, specifically around diet and obesity, and how we can help educate our population, who, particular section that don't have a lot of money, how they can eat well on particularly small income. So I think there are opportunities there for us to do something a bit differently. I'm not sure that quite answers your question.
Yeah, it does. It's good to know you're thinking that way, but it sounds to me like we're doing very little. You didn't mention any specific services that you're commissioning. You didn't mention any services that the council's involved in. And at the end of the day, if we're going to tackle this problem, we've got to tackle it at its source, and that's educating young people. We know more about the increase. What are we doing with schools? How are we supporting schools? How are we getting the message out to teachers?
I think, in fairness, Councillor Longden, it's not necessarily this question that is there anything that's going on that you can answer now?
I'm not a children's commissioner, so it's not my area of expertise, but it's certainly something we can take back, and I can find out and provide.
I'm detecting in the room that there's a willingness to make this a serious piece of work for next year. So I would just mention to all members that there will be plenty of time to go into this in full, not only with our colleagues from the CCG, but also people in the council who do this work. I think the exec member just wants to make a point, and then a quick one for Councillor Brophy.
First of all, yes, it's not just the CCG, it's also the council, it's public health. Just to say that we've got, under the health and wellbeing, we've got 3 boards: Start Well, Live Well and Age Well. And I know Councillor Bohr, who chairs the Start Well board, is looking at childhood obesity. So it is actually something that we are doing, starting with. The Live Well board is also looking at things like exercise, getting people to eat healthy, getting them to stop smoking and things like that. So there is some work going on. And if anybody wants to join or wants the notes from these meetings, then I am certainly happy to pass them on, because it's not, as I say, it's not just one group's problem, it's widespread, and we have to work together, and we are working together with the CCG to try and get those really good outcomes for people, and starting early rather than leaving it to the people that are coming to see you rather than
Thank you, Councillor Lloyd. That's really helpful input there. I'll just have a brief point from Councillor Brophy. Thank you for waiting, and then we'll sum up and we really must move on. So, Councillor Brophy, please.
I'm glad that Judith Lloyd said pretty much all the points here about the wider determinants. It is actually the role of council as our public health role to put these all together. So I think that I welcome that. I felt the point about the ethnically diverse people from actually there are different genetic predispositions even amongst all populations actually, and I do think there are some populations, poorer people as well, whatever, that have particular needs in terms of education, and I think that's something the Health Scrutiny Committee can address. And in terms of the education, I think the one thing I'd like us to recognise as a Scrutiny Committee is the scale of the problem. In fact, we're talking about 11,000 people here, and when you talk about 2 people running the expert course, the actual number of people we need to reach, and echoing the points of the council across the room, it's also about trying to reach the hard to reach people, because generally those people who will access the expert course are probably those who can already look it all up on the internet themselves. Everyone requires that type of support, and we need, as a Trafford, to make sure everybody with that diagnosis has access to a level playing field amount of support.
Thank you, Councillor. And there's clearly a great deal of expertise and passion on this issue amongst members of the committee, and assuming that the membership will be broadly similar next year, this is possibly something that we can pursue as a task and finish group with and getting people with all different disciplines involved. So thank you very much for that, everybody. And can I thank you chaps very much for coming and giving us the benefit of your expertise, and however prolonged the pilot has been, I think we'd all agree that it's a very welcome pilot, and we look forward hopefully to it being rolled out further in Trafford, and maybe we might see you again next year for perhaps a longer discussion on how it's going and what we can do to
shape services going
forward. Absolutely. So thank you very much, guys, and thank you for coming. Moving on, ladies and gentlemen, to item 7, physiotherapy. Again, the CCG. Is that yourself again, sir?
It's me again, yeah. Thank you. So, so there's a request for us to bring something back to explain to the committee about the work of physiotherapists and what we're currently commissioning. And the paper, so hopefully again you've had a chance to read the paper. It is quite long. Given the conversation we've had about diabetes, I'll try and be reasonably brief in terms of summing up the paper. So within the paper, we've kind of tried to give an overview. The question was really about physio, but it's difficult to talk about physio without talking about the wider multidisciplinary teams that exist within the services that are delivering care to our patients in the community. So what we've tried to do is give an overview of how physio fits within our currently commissioned community services, give an overview of those services and what they're currently delivering, and try and highlight any issues. Primarily the theme that we're going to keep coming back to is around access and waiting times to some of these therapy services, and talk about some of the service developments and things that we want to do moving forward. So in terms of the services that are set out in the paper, the key ones that we've really tried to talk about are the community MSK service, the community rehabilitation, an outpatient service, community neuro rehab services, and the pulmonary rehab services. So in terms of the community MSK service, just to give a bit of an overview, that's an integrated service which has the aim of treating more patients in the community. It's been in place since the 1st of July 2016, and again, it's a multidisciplinary approach, so it comprises MSK physio and podiatry, specialist orthopedics and rheumatology, and specialist pain services. So the idea is that it provides a number of specialisms under one umbrella, with those services being delivered in an integrated way. It's a good example of joint working because it's currently delivered jointly between Pennine Cares, our community provider, and also by MFT, who provides some of the more specialist input into the service. So the service has delivered a range of benefits, and we've listed those on page 33 and included some information on page 34 around demand. So the main issue with the current issue with the service is around access and meeting the waiting times. Currently, only 20% of patients are being seen within the 4-week target, although all urgent patients are being seen within 2 weeks. So the reasons for this are primarily due to vacancies within the physio team in the service. We'd also have quite high DNA rates within the MSK service as well. So to try and address some of these issues, a steering group's been convened, which has drawn up an action plan. And we've recently undertaken a GP survey as well, which has highlighted waiting times as a key issue. So this is something that the CCG is working closely with Pennine and MFT to improve. And I'll come back onto some of the wider programs of work we're going to try and do around rehab at the end, if I can. So the next service we wanted to highlight was community rehab and outpatients. So this is a service. It's 4 teams, 1 in each of the Trafford neighbourhoods, and it's focused on assessing individual patient needs and developing a patient-centred rehab programme with the aim of supporting patients to gain maximum independence in their activities of daily living and mobility. So it's delivered primarily by physio and occupational therapists, and it offers support of patients with declining health and those with rehab needs, and it's really about maximising their function. And it also treats patients who have potentially got a chronic disease and might be in decline. And it's a really critical service because it's about looking after people, supporting patients with frailty. It's really increasingly important as we have an ageing population in Trafford. But again, the main issue is with access and waiting times. So over the course of the last year, the numbers of referrals into the service have increased by 32% compared to the same period last year. So we've done quite a lot of work trying to identify patients who might benefit from rehab. So we've put in place a falls referral pathway. We've also embedded the frailty index into Trafford GP practices. What this has done is helped us identify a cohort of patients who have rehab needs who may not otherwise have been able to be referred into services. But what it also does, once you've identified those patients, you're referring them into the appropriate service, but we need to make sure that those services have the appropriate capacity to meet that demand. So it's great that we're identifying a need, but we also now need to work to commission services which have the capacity to meet that need. So again, that work's ongoing. The service is working with third sector organisations, including Age UK and Trafford Leisure, to try and provide alternative routes to treatment for those patients, particularly those who benefit from postural stability exercise programs. We're also looking at improved adoption of self-management and in delivering the stamp exercise classes within that service in a different way. So again, there's a range of initiatives that we're looking at to try and improve access. The third service that we wanted to highlight was the community neuro rehab service. So this provides specialist rehab to patients with acquired brain injury or a neurological condition within a community setting. Again, it's a multidisciplinary approach, so as well as physio, there's a clinical neuropsychologist, occupational therapists, speech and language therapists, dietitians, and nurse specialists. So it's about physio working as part of a wider team. This is a really critical service, and it's one that's been under quite a bit of scrutiny recently. It's got a key role in facilitating a discharge out of secondary care and delivering rehab to ensure that patients post-discharge can have their rehab potential maximised and can live independently, ideally in their own home for as long as possible. However, within this CNRT, we've had a long-standing issue with access and waiting times, and it was raised as a priority concern last year. Since then, CCG and Pennine have been working very closely to put plans in place, both in terms of the short and medium term, but also the long term in terms of what we're going to do moving forward. So last year, we made an investment of £106,000 to support the short-term recruitment of additional physio and OT support to try and address some of the waiting times. So that's been quite successful. So we've employed 2 locum physios. The waiting list initiative started on the 1st of December 2016, and waits for neurophysio have subsequently reduced from 81 waits to 31 over the period of 8 weeks that's been in place. We're now down to 10 waits overall, and that's a significant improvement, which is ahead of our expected trajectory. We've also reduced the patients waiting for first intervention for physio stroke has been reduced from 47 weeks to 26 weeks. So the initiative we put in place has made a big impact on the immediate issues within that service, but I think we've got a lot more work to do to ensure that that service can sustain that improvement as the capacity to meet the needs of our patients moving forward. Also, there's some information in here as well about pulmonary rehab, which is a program of exercise education for patients with mild to severe COPD. Again, it's delivered by Pennine Care in Trafford. It's delivered by respiratory physiotherapists and occupational therapists. And it's a course of rehab that lasts 8 weeks, delivered from various locations around Trafford. And it's about working with patients with COPD to improve their muscle strength so their oxygen can be used more efficiently, supporting patients to better cope with being out of breath, improving fitness and confidence, and improving their mental health and well-being and their overall ability to cope with their condition. Again, the issues with this service around access and waiting times. So we've seen an ongoing increase in referrals, so a yearly increase of 17% as of December last year, and that's contributing to long waiting times. So of 275 referrals that we received up to December 2018, 22 of those were waiting longer than 18 weeks. So again, we're working in conjunction with Pennine to undertake an internal capacity and demand review, which is looking at signposting to other service, reducing the length of the programme so we can see more patients, but it's still within NICE recommended guidelines for pulmonary rehab, reviewing long waiters, and ongoing review of wait times via our internal governance, both within Pennine Care and within the CCG. So I hope that kind of gives an overall picture of some of the key services that are employing physios. I think in every case, the physios are working as part of a multidisciplinary approach to support patients. In every case as well, the key issues with the service are about the capacity within those services to meet the needs and demands of the patients, and the, in some cases, significant waiting times that patients are facing to access those services. So rehab's a significant piece of work for us. It is a priority for us, and it's something that we'll be looking at moving forward. These services are critical in ensuring that patients are supported, that they're able to fulfill their potential, that they're able to live independent lives. It's increasingly important with the ageing population that we address this, ensure we've got the right levels of access. And we're working with Pennine, and we'll be putting in place a full review of all rehab services moving forward. I think it's a particularly opportune time as the Pennine services are currently in the process of transferring into MFT. I think that provides lots of opportunities for us to look at synergies we can potentially deliver with secondary care and some of the community teams over in Manchester. But I think they're services that are critical. They're doing a great job. They're employing great people, but we need to make sure that patients are able to get in, and they're able to get in a timely manner.
Thank you very much. We'll start with our resident physio, Councillor Taylor.
Okay, so yeah, well, thank you very much for that report, and I'm so glad to see this has come to this committee. I declare an interest. I am a physiotherapist, but I don't work in Trafford, but I have some knowledge of services in Trafford because one of my roles is I work at Manchester Met University, and we have a number of our students who have placements with the teams in Trafford, and I think, you know, you've highlighted the key issues. There's some excellent services, some brilliant practitioners, and some really innovative services in the community in Trafford, you know, and provided by some really committed teams. But I think the issue is access, and I think that's a huge frustration for, well, obviously those who require the services. And I think particularly I would draw attention to the neuro rehab team because particularly patients who are maybe discharged back, they've had an acute episode, maybe a stroke, or maybe a period in the intermediate neuro rehab unit, and then their progress is actually regressed by the fact that they cannot access those services in the community. So it's actually detrimental to them. They're not just sitting there remaining stagnant. Their progress and their journey towards independence and being able to self-manage is actually being retarded by the fact that they can't access those services. Absolutely critical, and they've had all that investment whilst they've been possibly inpatients, and that can't continue. So that's really a huge worry, really. My other question was going to be, with the possible closure of George Carnell or changing functions of George Carnell Leisure Centre, a lot of those pulmonary rehab services are located there, aren't they? And I think it's brilliant, the integration between, and I think that's quite another innovative thing, the integration between leisure services and primary care services, but where will those services then be located and offered? And just thinking about sort of the integration of Pennine Care with MFT, how those services going to look going forward, really. But I think the number one thing, and I think you've highlighted it, really, I think you're aware, but what particularly is being done to address the issue with the huge waits with the neuro rehab services. And as I said, it's poor for the patients, but it's so demoralising for the staff as well. The staff who work in those services, they want to provide a really high quality service to the patients, and they're frustrated in their ambitions because they haven't got capacity to reach those patients. And I know that staff have left the services, and that's, when they've had investment in them, in their own training, and then to leave and take all that expertise elsewhere is tragic, isn't it, really? So an impassioned plea from a fellow physiotherapist to really address that as a matter of urgency.
So yeah, I'll absolutely welcome those comments. I completely agree with everything you're saying. It's a massive issue. There's been a particularly acute issue within the community neuro rehab team, as you've highlighted, but the issues that you're raising aren't unique to that team.
No.
Within the wider community rehab teams, we do have issues with hospital teams perhaps struggling to discharge because of lack of capacity within those teams.
Absolutely.
That's leading to long lengths of stay. It's leading to patients becoming more frail because they can't get out of their hospital bed. They can't get moving in the way they would necessarily be able to do in their own home. Then when patients are discharged, the long lengths of they're having to wait before they can be seen by physio is resulting in a regression from the work that's been done.
Putting them at risk of possibly readmission even, isn't it?
Absolutely. It's got wider impact. It is contributing to, as you say, readmission. Potentially it's social isolation. Trafford has a significant problem with the number of falls and admissions as a result of fall. So I think completely agree, neuro rehab is a bit issue, but it's a theme across all the services.
Absolutely.
Really. I think to just your specific point around neuro rehab, it is an area we've done a lot of work in. We have made an investment to reduce the waiting time significantly. We need to do more work, and that work is ongoing. It will, and Richard, I don't know if you might have something you want to add, but it will form part of the transition of services.
Could I come in, Chair, and just help with just provide an update about neuro rehab, because we've got a specific question. Is that okay? So welcome the comments that you've made about the quality of the staff, and I've spent some time in the last couple of weeks out doing some visits with the community team, so I agree with what you're saying. In terms of neuro rehab, and the comments that Brooks was making around Manchester Foundation Trust, I think we've got, and this is an issue generally, that I think where you've got quite small specialist teams and community services, there's definitely some benefits of the joint working you can have when you move into a bigger NHS organisation. And I think neuro rehab is an example of that, because as you highlighted, the staff are really excellent there in terms of their expertise and skills. So we've met with Manchester Foundation Trust last week and identified that as one of the early wins in terms of improvements, so that we could review the pathway with them, because I think, and you'll know from your expertise, I think people are getting a different type of experience at different points when they move from the
Absolutely,
hospital-based
yeah.
services to the community. So we've agreed to do some mapping of those journeys that people are making and looking at what improvements we can make now ahead of the move. There is an upward pressure, so we've done a fantastic job with the waiting times, but they're still too long, aren't they? So even if you say, well, we've halved them, but even at half, they're still too long, and it's having an impact on people's recovery. So I think we would all take the view that it's not acceptable as it is, even with the improvement, though it's very welcome. So that's what we're doing with that, and I'm fairly optimistic with the approach that from the work we've done with the Foundation Trust, that we can make some gains there. But I do think capacity is the problem, and that comes back to make some choices. I think about where the service offer goes and targeting it at the right places as well. But neuro rehab's our top priority in that.
Thank you.
Any further on you?
I'll let somebody else have the opportunity to
Thank
ask
you.
a question.
Councillor Mrs. Haddad, please.
Thank you, Chair, but Sophie's raised my questions. Thank you.
Thank you. Councillor Mrs. Brewer-Morris.
Thank you. I'm just referring to the pulmonary rehab, which, because I look after COPD patients, and the uptake for my patients is really bad. I don't know why. And yet those that attend come back and improving the muscle support, strength for oxygen. They rave about it. They're breathing better, but can I get them to go there? I don't know. Tell me how. It's at George Canal, which we don't know whether it's closing or that's up in the air. What other areas of Trafford? Does Alta General and Trafford General also run COPD pulmonary rehab?
I think it's run out of Trafford General, and I think it's also run out of the south of the borough, but I can't remember the exact location, so I could provide that
some
afterwards.
services in church halls and things like that. I know they do one at St Matthew's Church Hall, don't they? In Stretford, they run some pulmonary rehab services there as well. But I think the base is at George Carnell, isn't it?
We could put it in the Altrincham hub.
Chair, if I might just quickly add about pulmonary rehab, because I think it's a similar scenario from our point of view, that actually what we need to do is look at the whole respiratory journey. And we've got a programme that we're doing with Dr. Kane, who's one of the lead respiratory physicians, who's based at UHSM, which is MFT now, isn't it? And so I think part of that work, again, will focus on it. But you're right, with those programs, they're very, very successful for the people who stick with them. But the challenge is, as you're identifying, for the patients that you're working with, a number of people don't, and we need to really have a think about that, because the staff are really busting a gut in terms of where they're doing it and how they're setting it up.
I just wish I know that I can get patients to go if I really sell it, what's been offered to them. But sometimes you just don't have the time in surgery with your 20-minute appointments or 10, whatever we have.
Councillor Mrs. Haddad, a brief point.
Just briefly, really, on the back of that, you did say that you've got a large instance of DNAs. So what work are you doing around that?
Is that within the MSK service specifically? I think I'd raised the point around the community MSK service. I don't know, are you better positioned to answer this than I am?
Yes, I think it's a challenge, isn't it, around offering people choice around appointment times and how you fill the demand that you've got in services. So what we find with the MSK service is that people are choosing appointment times which are further away than the immediate time. So we're having to rethink how, it's how we manage that in terms of the gaps that we've got, and that's something the team have got a number of pieces of work in place on at the moment, which is highlighted in the report.
So when you're managing it, I mean, most hospitals have this system now where your appointment's way ahead, but nearer the time, the day before, they text you. And do you have all that system in place?
Yes, we do. We carry out the reminders and so on, but it's not an unusual situation that people make choices about when they have it. I mean, I think one of the things that's highlighted, hidden in the report, but it's highlighted, that we've done lots of online work and that's been really positive. So we're encouraging people to see the online programs as well and copy those. And that's had a very significant impact. When we did the review last year, we found that it reduced people's using the sort of physical service by about 8 to 10%.
Councillor Taylor, you wanted to make another point?
I'm just really thankful this has come to the committee, and I think it's like the previous item that we discussed, the diabetes, isn't it? I think the scope here to improve the health of the population is massive, isn't it, really? And prevent things like hospital admission and sort of deteriorating health in the community, really. So it's just to say to the chair, I think we'd like to bring this back, you know, and obviously there's a whole programme of work going on to try and address a lot of the issues that are ongoing, and it'd be just nice to review that, really, and to see how things are progressing. So I think we would like to bring that back as another item in a few months' time, maybe.
I was going to suggest that, actually, so that's really welcome. So what we'd agreed with the commissioning team at the CCG was that neuro rehab would be our priority for obvious reasons. We've got a programme, we're making good progress with that now.
Yeah.
And the next stage is doing the broader review. We've done all the scoping work for that as from a provider perspective, so we're about to start that. So my suggestion would be that we could bring that back at the right moment and share the outcome and the plans coming on from that.
Yeah, I think it'd be quite timely with the advent of Pennine Care Services merging into MFT, because I think that will be quite impactful, won't it? And
well,
I think
I've done about 40 meetings with our staff now around the move to MFT, and I would say the physiotherapists are the happiest group of staff.
Yeah.
Everyone's positive, some are very positive and some are ecstatic, but the physiotherapists are really pleased because that's an area of service, particularly right across the therapies, where they can see those significant gains happening.
Yeah, brilliant.
Well, again,
Thank you.
like the previous subject, I think that's something that we can bring back in the new year and the new municipal year and discuss. So thank you, everybody. And thank you for your contributions. Yes, and by all means, if you want to, you don't have to stay for the rest of the meeting. We won't make you do that.
Long meeting.
Yes. Moving on, agenda item 8, which is in your to follow report. I think if we just slightly conscious of time, because the previous 2 items have overrun slightly, if we could just run through that, Diane, as quick as you can.
Well, thank you, Chair. We will go quite quickly, although I know it was a key question asked by a member of the public, so I do want to make sure that we cover and answer those questions. This was a follow-on, a feedback, if you like, request from the committee from a presentation late in 2017, early 18, around the opening of the control room and the emergency response that we're making for urgent care. So Richard and I are going to just quickly take you through this between us. Our approach to this is it's a journey, and we are learning very quickly and adapting things as we move forward. But one person delayed is one person too many, and that's the approach we continue to take. If we could, is the presentation going up? Shall I move around there and press the buttons? Lovely. Sorry about that, Chair. So in 2017, many of you will remember we had about 100 delays every day across the whole of Trafford in the 4 hospitals that we serve. And so we took the decision to take a different approach to the control, if you like, of the allocation of resources we have in community to people that required them. And we opened the urgent care control room at Meadway Health Centre, which is a community resource, which is open 24/7, basically. We put all of our services together. And when we first opened, it was a very small room with 2 staff to actually run that service. And I'm going to show you the picture. It's considerably grown. You can see the staffing now here. And we've linked in staffing across discharge to assess, the reablement type services, stabilise and make safe, we call those, Ascot House and the intermediate care, and each of the 4 sites, for the 4 hospital sites, feeding to us, if you like, everybody's details that needs to go home, what they need, and then we can facilitate the resources required to meet those needs as people move home. Medway Health Centre also has the Community Enhanced Care Service, known as CEC, that many of you will have heard of before. It now has the out-of-hours emergency social work team, so that we can ensure that we can respond at night, and the overnight night district nursing teams as well. So we've now got a whole coordinated response base from that building. It's helped us to really focus on the experience of people moving home, but also the pathways that need to change to support that process. And I'll talk you through into the delays now, which are considerably lower, but still too many. So that's the control room now. There's about 12 to 15 people working in that team across the board now, and they are in the room next door to some of those nursing teams and the urgent therapy team, so we can utilise that support.
Okay, we're doing a double act. As you can see, it's a smooth transition between us, hopefully. So this is in terms of what it does, and I think this really came out of a question about how can we know and understand where people are in Trafford when they move into the community, or we want to keep them, support them to stay at home, and make sure they're in the right place, and make sure those movements are the right movements and are the safe movements from their point of view. So we share this information daily. In the next slide in a moment, we'll show you a picture of a screenshot of how the slide looks from our point of view, and this gives regular updates. So it's very innovative, really. I think we were the first place in Greater Manchester that was doing it. So we have a live update of everybody in terms of capacity and where they are as well, and we use that to manage the movement between the different services we've got in the community, and make sure that's done in a timely manner. We're also now moving it to be the point of escalation. So the next point, and this is about us working much more closely with primary care and GPs in particular, is that we'll be able to start to use this as a point where people can make a single phone call and hopefully be able to support people staying at home rather than going into hospital. Do you want to just do the next slide? So, Diane, there we go.
I will if it works.
Okay. Right. I think we've probably pretty much covered that now, haven't we? I think, is that the...
Yeah, I think some of the things that we've been looking at in November 17, we opened up what we call discharge to assess beds, which enables people to move out of hospital to somewhere where we can complete assessments and also people have time to make decisions. I think Heather mentioned last time we met here around some of the difficulties around making long-term decisions in a hospital setting where there's a lot of pressure to move people out so it can get access to that bed. And the discharge to assess beds gives some of that capacity and that time. When we first started, we had 7 beds across a number of homes in Trafford and 9 at Ascot House. We now have 36 discharge to assess beds and the ability to go up to 50 during this particular very busy time, and we are utilising those. We also have moved to trying to focus much more on the step-up capacity, supporting GPs to be able to have that conversation about where else could they go. And that links across into the MWAS conversation around having a sort of agreement as to where they could take people opposed to a hospital. We changed quite a lot of the criteria of services to try and maximise the use of services. And we have recommissioned our stabilise and make safe, our reablement offer, and we've moved from having 3 suppliers to 7 suppliers. So the capacity in the market has considerably expanded. And that some of the outcomes from those services, particularly stabilise and make safe, is 90% of people are going home very successfully and not having readmissions. So it's important that we move people back home quickly, but it's also important that we do that safely and appropriately for the person.
Okay, so moving on, so we, from a Greater Manchester point of view, we are set a national sort of allocation of the target around delayed transfers of care, which is 3.3%. So this is the figure we should be expect to have on a daily basis, no more than 17 people held as delays in hospitals, and this is how it's set out. So the next question obviously would be how are we doing against that. So Dan, if you want to move on to the next slide. So actually, so we've got a screenshot there of, this is the copy which I was mentioning earlier around what the immediate report looks like. And so we get a daily update on delayed transfers of care. And I think one of the things that's a benefit is from our joint working is when we talk to colleagues from Salford Royal, MRI, or the Wythenshawe site, we all know in our services exactly what's going on and are able to address that. And this gives you a partial picture of how that would look like and how we'd work on it on a daily basis.
So going back to the beginning in December 17, we had 100 people delayed a day. We are now down to around about 15 to 20, 25 at peak times. So it's a massive reduction. But going back to the question earlier, if that was my dad, I wouldn't want him to remain in hospital a day longer than he needed to. So we still have work to do. And if you look at the what says MO, which is medically optimized, that means somebody is nearly ready to go home, but not quite. That's the group of people that we're trying to work with now. And those numbers have grown considerably with the work that we're doing with each of the acute sites around length of stay. So we're looking at all of the reasons that cause people to be in hospital for a longer than necessary, including tests and x-rays and all sorts of things, right through to the destination and the solution. So the work is shifting across more to working on, can we shrink the length of time that you're in hospital?
So how are we doing? I always like chance to go in this direction. So you can see this is a screenshot from January 17, so it's performance over a period of time. And as you can see in the left-hand corner, top left, you can see the situation we were in sort of 12 to 24 months ago with really high weights right across Trafford, and the impact that we've had on that is very positive, as you can tell. I think the only thing that you'd say is that clearly demand does go up and down through different periods, but what you will notice with the increases is that with the work that we've got in place, we're able to bring that back down very quickly now, whereas previously figures used to go high and stay high for quite considerable periods of time. So from our point of view, as Diane said, we've got a lot to go still, and it's a daily challenge for us. You can see some very marked improvements in terms of performance as well.
So these are the pathways that we've been talking about, and we're just going to give you a little bit of detail. So we've agreed with across Greater Manchester, these are the pathways that all hospitals and all local authorities and all CCGs are working to. So if you can go home with no support, you're on pathway 0. If you're on pathway 1, it's additional support in the home, which would be stabilise and make safe, etc., etc. And we're very clear who fits into each of those lines, if you like. And this is helping the teams to make quicker decisions. However, there are still challenges. So this is not an easy situation to manage. As you know, some of the work that we did and we brought to you at, I think, 2 meetings ago, was around some of the reduction in our care home capacity. So as I took over as corporate director, along with Mary Moore, who's the chief nurse for CCG, we made a commitment that we will not accept poor quality provision. And we closed 5 homes with the support of CQC and colleagues across the sector, which took us 150 beds out of our system. However, 150 beds that are of poor quality are no use to me at all, really. So the impact of that has been felt. In December 17, we had about 98 beds every day that were empty in our care homes. And it did drop as we closed the homes, it did drop, and I was getting a little concerned. So we've done a lot of work on new provision options, which I'll talk to you about in a minute. However, we are running at around about 50 empty beds every day in our care homes. And it's a difficult balance, that, because an empty bed means instability for those homes. So if they are empty, they have not got an income. So that causes other issues for me around potential closures. But it is good to have a number of beds so that you can create the flow you need through residential nursing homes. Another key issue for me is the lack of EMI. I'm trying really hard not to use acronyms for you, but beds for people who are dealing with dementia in their life. And what we have done is we have purchased some block purchase beds at Woodend and at Peel, which is actually in Manchester, the Peel, as a short-term option while I work through some of the bigger solutions around the new market offers that we will be developing. This is a national issue. There are a number of authorities in GM struggling and across the Northwest, which I've been talking to around some of the options that they have, but we have put some interim plans in place. Again, the quality issues for people with that particular issue in their life are really, really important, because we have to support the families to be the voice of that individual. So there's other issues to take account of. The other positive work around the discharge to assess beds is that as people move out of hospital into that interim place for their assessment, if they then need to stay in a residential or nursing bed, the homes are working really well with us for them to remain in that home and not have to move again. So we can convert them into long-term placements and then purchase additional beds for short-term assessment elsewhere, which has been great. The other thing that we've seen from those beds is we've actually seen people go into discharge to assess beds at a very high-end dementia type support or behavioural support, settle really well, and either move down to only requiring general nursing support, residential support, and we actually have had people go home, which is a real positive outcome for the individual going through that process. We are learning more about those beds each time we utilise them, really, and we're also looking at the moment we have them in about 7 or 8 homes across Trafford, which is great for access for visiting. Not so great around assessment capacity because it's very spread out. So we are just having a look at that going forward.
Okay, so moving on, and we keep coming back to, and we won't make any sort of apologies for this, about this is a people story from our point of view. It's not just about managing the performance. So safety and the quality of what we're doing is as important from our perspective. So in terms of a safe discharge, the journey would be that you'd have an assessment by the social worker who would identify any barriers. We've got navigators based in the emergency department who are able to prevent unnecessary admission through providing a range of practical solutions and options. The control room would liaise with the hospital discharge team to ensure discharges are planned and appropriate. We've got a care at home team who would follow people home after a period of intermediate care, or specialist support from the specialist community nursing team. We've got discharges which are referred to the Care Coordination Centre, and obviously that's something different, but they provide long-term conditions management in Trafford, so they provide a really important role in terms of supporting that. We do occasionally have poor or failed discharges, though if you look at the number of discharges that we're facilitating, those are relatively small, but we carry out reviews of those because they can often be issues that would happen across the system that we work in. And then also we would make onward referrals to other community specialists like matrons and the district nursing and the therapy teams, which we were talking about earlier. And then the final thing, which we're doing some more work on at the moment, is making sure that we get equipment into people's homes quickly and well in terms of helping them to manage independently as well.
And Chair, it may be really interesting. Numbers are always helpful, aren't they? So in December 17, in the month leading up to Christmas, we launched our first Home for Christmas campaign, and we discharged 91 people in that month. In this year, in December 18, we discharged 196 people. So we doubled it. And we are running at around about 200 discharges a month that are facilitated through the services. So it's a massive increase. However, we still have a way to go. I'm going to skip to the future just for speed for you, really. So some of the changes that we're now focusing on are some of the from some of the learning really. So we've launched a new triage process at Trafford at Wythenshawe Hospital, which may help some of the questions that were asked earlier. So we've put a senior practitioner in that will take a look at people when we receive that medically optimised notification. And if they can go home at that point, and we can facilitate that discharge immediately without waiting for Section 2, which is a notification for assessment notices. And we're trying to cut out a lot of that bureaucracy. We're going to continue. We have very close working across a system, and Mandy Bailey from Wythenshawe Hospital is part of our LCA and is supporting us really with thinking much in a very different way and reaching into the hospital and working in a different way. We're expanding further the discharge to assess opportunities. We've currently got 3 step down accommodation flats, extra care flats at Limelight that we've opened for people where they can't return home because there's something wrong at home. We had somebody who the ceiling had fallen in, the heating isn't working, etc. So that's a different and a new option that we're just testing out. We're looking further at 7-day working. We have 7-day working at Wythenshawe Hospital, not on all our sites from a social work point of view. And I'm just looking at what requirements there may be going forward. We're continuing to develop the home care market, which I'll talk on the last slide for you about. We're building further resilience when we have peaks and troughs. So we know the usual Christmas, Easter, and summer peaks, but there are others appearing that seem to repeat, and we're just looking at how we can manage those. We've recruited and just waiting for somebody to start for a new team leader post at Wythenshawe Hospital to support the team there because of the capacity issues on that site, because that is our biggest activity site. And we're working up a proposal at the moment with GPs around how we use the control room for that one call to say, I will have to admit this person if I cannot find a solution. Where might that be in the control, and then facilitate that opportunity to avoid an admission. And then I am very excited about the home care changes, which I know the committee has asked a lot about over the years. We have been to the providers with a number of innovation options, which will be going out in April to procure. And these include walking rounds. So moving from, if you remember, we had a very large number of home care providers in Trafford in order to get the capacity we required. And now we're trying to get back to the patch-based delivery, which means that we can support other policies like the clean air policy, etc., around walking or cycling around the patch. People know their patch better. They can help support people into activities within their area, etc. Rapid access to that stabilise and make safe service, or having dedicated hours ready to take from each of the hospital sites. You'll love this one, home care in hospital. So when you go into hospital, normally most local authorities hold a package of care open for usually up to 72 hours, 1 or 2 authorities slightly longer. And we're discussing how long that package could be held open. We're talking about a week or 2 weeks possibly. But also you lose contact with your provider. So we are proposing with the providers that not at the 4 visits a day, but a couple of hour slots, they would go in and visit the person, taking clothing, personal hygiene stuff that they might need, and work with the ward around saying, we're ready to take somebody home as soon as you are ready. Now, that one is particularly very exciting for me. There'll be another lot on reducing socialisation. So if we can get to the point where the providers are doing walking rounds and they know their patch really well, they could link people into some of the social activities and the community groups, etc., that are working in those areas. That takes time, and we've got other proposals to help the sector with its recruitment to enable us to get consistent staffing that enables us to train them up to the standard and keep them in social care in general. And then the last one is a dedicated stabilise and make safe step down service for our discharge to assess. So some of the positive experience we've seen at Ascot, where we've linked care at home as the service that takes people from Ascot and works with people at home for 3 weeks to make sure they don't lose any of the work. I think you mentioned before that losing the skill that you gain whilst you're in hospital and rehab, that you can take that home, and this would help those discharge to assess beds. So those are the proposals that we've got coming in. And then there's just a little good news story at the end, because I always like to end with the person at the heart.
So just finishing with a people story. This is about somebody called RB who was transferred to a discharge to assess bed from hospital. No previous involvement from social services, but at the time he was ready to leave hospital. It wasn't safe for him to go home, and his home environment had been condemned. He was presenting with some significant mental health problems, including some delusional beliefs. And prior to admission, he was very isolated from his family and friends, which is a very common story for people with mental health problems. Prior to discharge to assess, he's likely to have had his long-term decisions made in hospital and probably moved to living in a care home. So what did we do? Assessment started in the discharge to assess placement straight away. Housing were contacted, referrals made to mental health services and the GP, so pulling in that multidisciplinary team to wrap care around him. Support was provided for advice and finances and to rebuild relationships with his family. And we also brought in some legal support to help him manage his affairs. And his care needs were assessed during the period that this was happening. For discharge to assess, following completion of all the assessments, he was discharged to sheltered accommodation with support from rehabilitation services 3 times a day, subsequently reduced down to having no care requirements as he was managing completely independently. He's now engaging with the scheme activities, and nice story, went to Blackpool for Christmas, and he's rebuilding relationships with his family and seeing them regularly as well.
Very much. Are we just slightly conscious of the time? Can we make points very, very brief, please, Heather? Just turn your mic on.
It's really good news that there have been the levels of reductions following the CQC local review last year. I think it's also good that we're looking to standardise some of the pathways so that we're working on a level playing field and categorising people in a standardised way when they want to come out. We have, I think, the choice of care home. We've recently done a report on that, and what we found is that it's really quite problematic for people to know where to go to try and find out where to go for a care home. I don't really think that the public truly understands what some of the key factors are in choosing a care home, and it's obviously a difficult position. We are very supportive of the enhanced care team, which is at the moment on pause. And we had a workshop on that on Tuesday. And we will certainly be supporting the evaluation and going forward, because I think that the true worth of that pilot has not been evaluated sufficiently. And one of the issues that came out of that, and not one that I'm passing any judgment on, but we know that we had the trusted assessors introduced, so that there was only one assessment on people coming out of hospital and then going into the care home. But I was with the group of care home owners, and they are violently opposed to that. And the rationale for that is that they are the people who know how someone will fit into that home, and they have to fit in with the other residents. And what they don't want is someone sitting in a hospital and saying, you can go into this home. So I think as part of the overall evaluation, we need to take that into account. But I think otherwise progress is being made. So thank you.
I absolutely thank you, Heather. I really, I welcome your feedback on it, really, because it's it's a lot of work, but it's not something we can stop on. On the care homes making decisions, they are very, very clear that they have to make their own decision because they have to be able to meet the needs of the individual. However, the discharge to assess response times is 24 hours, so they need to be in the hospital assessing within 24 hours. And the ones that we now have really stabilised with us are doing that, which is great. It's the long-term placement decisions, I think, that homes are still quite insistent about.
Thank you. Councillor Mrs. Brewer-Morris, please, quickly as you can.
Yeah, as quick as I can. Thank you for the report. I too also feel that progress is being made, and it's really good to hear that. Just about the Wythenshawe thing, this must be about the third time you've brought a new initiative between Wythenshawe and sorry, it's getting late, and discharges. Thank you. It's been going on for 2 years, hasn't it? And we keep looking at it and it falls apart, and then we put in a new initiative. Hopefully this one may work.
I don't think it really falls apart. I just think it's and it's really interesting because I'm now the lead for GM on urgent care and on resident nursing, so I've got a personal responsibility to make sure all this works long term. But the change that we have had to make has had to have foundations, and then all of the different services going in as the changes come in. And I think that's why it's probably something that will never end, because as every time we get the new services in and the numbers start to drop, the increased presentations at the front door of A&E increase. And so you will always be working to be better, I think, which is why you probably see us coming back. And just on the Wythenshawe Hospital, Wythenshawe is the biggest activity for Trafford. That's why you hear it more than others. So it's Wythenshawe, Trafford General, then Salford. That's the order of our activity. So we do have a lot more work to do in Wythenshawe because of the numbers.
I mean, I would say that the changes are about trying and improving rather than trying and failing and changing. So you're right, there are changes, but that's part of the sort of continuous improvement cycle. And, that would be shown by the data that we were sharing with you earlier, I think.
I think in fairness, you've spent years battling the demographic pressures that we suffer in Trafford. It's not necessarily a case of things starting and not working. As you say, it's just improving things, isn't it? Councillor Taylor, very briefly, please.
Briefly, again, very, very supportive and really excited about some of these innovation plans that you have. And I just commend you for your tenacity in commitment to quality improvement, really, and continually refining this process. Actually being asked to ask this question on behalf of one of our members of the public here. Where in the journey would any financial implications be for maybe users of these services? Do discharge to assess beds cost service users anything to be accommodated in that way?
Okay, so the pathways that you go home with the support for 3 weeks, or you go into a discharge to assess bed for 3 or 4 weeks while we do that process, those are free.
Yeah.
It's only at the point we have a solution that is readily available and we're ready to move you on, that then if you can't or won't move on, then we do charge you. So if somebody says, yeah, I'm not going to that provision that you found for me, I'm staying here, then we will charge from them. But those are very personal conversations because we have to do a lot of work, as Heather's pointed out, around the person's income, their ability to pay, and all the other things that go with it.
Yeah. Okay. Thank you.
Well, thank you very much. And as others have said, Dan, it's clearly something that is being worked on very, very hard. And from other conversations, I know how passionate you are about this. So thank you for you and your hard work and your team's hard work. And I hope that this will continue to come back to us, because it has been a matter of concern for the committee, delayed discharges for a long time. So I've no doubt that we will be hearing much more from you again. But, thank you very much. Moving on quickly as we can, item 9, which was for noting the report from Health Watch on page 41. As ever, all I will say is that it is of the usual high standard that we've come to expect from Health Watch. Very clear, very concise, clearly method gone into it, and gives us a good overview as to what's happening in that particular home. So please keep them coming, because we do find them very, very useful. So thank you, Heather. Any points on that? No, super. Thank you very much. Moving on then, item 10, the task and finish group work. On A, the community services task and finish group, we have another meeting a week on I think it's a week on Friday, isn't it? 22nd, yeah. Where we will be, obviously with the merger, the transfer of the community services from Pennine Care to Manchester, that the work will probably be ongoing, and given that the deadline has been extended slightly, I think we will be looking at that possibly continuing next year. However, we will probably be in a position where we can finalise a report and make some recommendations by the end of this municipal year. So it has been a worthwhile exercise, not least with reference to phlebotomy, which is what we started on in the first place. So more news of that, I should think, in the report that we submit to annual council. But item 10B, which is the period poverty group, which you were covering off, weren't you?
There is a report that you will have received or will be about to receive. Is that? Yeah, so you can actually read that yourself. I have to give enormous credit to Alex, who has compiled this report, and we've sort of had the meetings and had the discussion, but essentially Alex and Sarah Grant as well have done some really sterling work in pulling all of this together, really. So this documents the journey that we went on, the ideas behind it, and where we've sort of got to date, really. But we couldn't have done it without Alex's support. He's been tremendous. And I would like you to minute your own hard work, please, Alex. So the summary, really, we've undertaken, you can read it yourselves, but there's a number of recommendations that I'm going to take to the executive in a couple of weeks, and hope that they will be able to adopt those recommendations, and we'll present this probably as well at council, won't we, as well, the findings, and I think we've been able to do some work to hopefully eradicate period poverty in the borough. I'm going to an event tomorrow night at Limelight to celebrate International Women's Day, and we're going to champion some of the work there as well. And we're hoping to have an event in early May after the elections, a borough-wide event that we're going to have people like the Red Box Project every month, and invite anybody from across the community to come and explore this issue and talk about some of the steps that we've taken forward to tackle this problem. Do you want to add anything to that, Jane? Because Jane's been part of the committee and she's been a brilliant advocate for it, haven't you?
No, just really like to thank Alex for all the hard work that he has. I bet it's been like herding goats or
herding
chickens
cats
or whatever.
Yeah.
I think it's been really difficult to get us together sometimes, but he has actually been brilliant. So I'd like to thank him and the staff that have been supporting us around that. And I think that in May, when we're able to do the event, I think that it will be we need to be doing more in Trafford. We did become aware that there was a real serious issue in some areas around period poverty, especially for school children not being able to go to school because of periods and stuff. So I think that I think it's real good work, and let's carry on in the next municipal year.
Absolutely, something we want to embed, and I think we'd like to bring it back and review it and check that work's continued to be carried out, really. So thank you, Alex.
I'm sure the committee would also thank you for your hard work and your team. And obviously with all the task and finish groups that we're doing, it is the intention that we should look at them again in the next municipal year and check progress against what's been recommended. So thank you very much for that, guys. Item 11, Joint Manchester Health Scrutiny Committee. Do you have any update?
I don't, because I haven't been to a meeting since we last met, but I'm going next week. So had we had this meeting in a week's time, I would have been able to bring you some more news. But yeah, I'm going to go next Wednesday morning, and there's also a training event next Thursday afternoon that I'm going to go to as well. So I'll report back next time, I guess. Yeah.
Sorry. What's the training event?
I can't remember off the top of my head. It's in my diary to go to it, and I can't remember what the topic is. I've agreed to it, so I can send you an email, Denise. I'll send the committee an email, or I'll send it via Alex, and if he could circulate. I'm just trying to look. I can't quite. I apologise. It's escaped my. I know I'm going to an event next week, but I can't remember.
I'll forward that on.
Sorry, I should have been a bit better prepared for that, shouldn't I?
But, thank you very much for that, Vice Chairman. Yeah. Right, just on urgent business. You will be aware of the coverage of the Altrincham Hub Ernst & Young report that was published this week. We've had a meeting today to discuss the work programme for next year, and the Vice Chairman and I have discussed it, and we think it appropriate to clear the agenda of the next meeting, which will be in June, to make sure that mostly, anyway, there will be another small item, but that mostly that discussion takes place to discuss the Altrincham hub, to speak to the CCG and to ascertain. Obviously, we have had some discussions about it already, but to very clearly ascertain on behalf of the public how the situation was got into, and what measures will be put in place to prevent it happening again, and also what's taking place to ensure that that building has as much clinical use as possible. And I think we must be very clear that the current management of the CCG have inherited this very difficult situation and have been doing everything they can to deal with it. Obviously, we need to provide challenge as a committee and make sure that that's being done in a manner that the public would approve. But I think we just need to do that as a full body of work at that next meeting, and then take a judgment at that meeting on whether further committee work is required to really drill down into it, which maybe it will. So I hope that you will endorse that approach that we've agreed. So with that, I have no other urgent announcements. This, as I said, will be my last meeting as chairman. I'm sorry it's somewhat extended, but I think that goes to show the passion and experience of the people around the table in the room. So can I thank you all very much for all your contributions this year. I think we've had a very, very good year. There's still a bit of work to do, but this will be the last main meeting. Can I thank my vice chairman for her support and for being generally supportive and helpful and cheerful and cheering me up at every meeting. And can I thank Alex as well for the tremendous work he does in supporting this committee. I couldn't have asked for a better support officer. And I very much hope after next year that I will be back with you as a member of the committee. So thank you very much.
Can we thank you, Rob, as well? And for your excellent chairmanship, and wish you well in your mayoral year next year. Thank you.
Thank you very much, everyone.